My name is Laura Ferguson, and I'm a registered nurse, and I'm responsible for overseeing quality improvement at Curana Health Plans. CMS oversees star rating programs for many organization types. Hospitals, nursing homes, and providers are all subject to different quality measure performance ratings. Health plans are also subject to a star ratings program. The Health Plan Star Ratings Program is a 5-star quality rating program, and it's based on a set of measures designed to assess whether health plans are providing quality care to members. Health plans are ranked annually on a scale of 1 to 5, 1 being the lowest score and 5 being the best possible score. Star ratings are publicly available to members, and new star ratings are released at the end of every year around October. These star ratings allow Medicare beneficiaries to compare health plans and make an informed decision on which plan they want to join. New Medicare Advantage organizations are assigned a new contract status for the first 3 years. This allows the health plan time to make sure their processes are in place to impact quality care, and that they can collect all of the data necessary to ensure that their star ratings are reflective of the care that's being provided to the members. Star ratings can have financial, marketing, and overall contract implications. If the health plan is rated below 3 stars for 3 years in a row, CMS could terminate the contract. It is really important for all of us to work together to make sure that we can not only improve good quality care for the members, but that we can collect that information and appropriately present that to CMS when it's time. The design of the star ratings program is a little complex. This slide outlines when care is provided to the member on the left side of the arrow, to when the plan could potentially be qualified for an additional bonus payment from CMS based on that care provided. As you can see, it takes 3 years for a plan to be recognized for good quality care. The bonus payment that the plans could qualify for helps the plan provide additional benefits and resources to make sure that we can continue to provide and improve care over time. In addition to the star ratings program, the health plan tracks many other indicators to gauge how well members are being cared for. The model of care outlines how the health plan has designed their care management program to not only meet CMS requirements, but also meet quality of care standards that are focused on improving outcomes. You will receive annual training on the model of care. HEDIS and display measures are industry standard measures that we track, trend, and monitor to help identify areas of focus and improvement. We review reported potential quality issues to identify areas of opportunity in the course of members' care that could have been improved upon or prevented. We also use this information to track similar incidences and to collaborate with the plan medical director and facility or provider to offer suggestions for policy or procedure changes that could support improved care. There is a form on the plan's website that helps facilitate reporting of such issues, and these can be submitted through the provider portal. CMS requires the health plan to have a chronic care improvement program. During the first year of business, the health plan will analyze claim data and select a preventable chronic condition in order to work together to try to make improvements in outcomes. Typically, in our plans, we focus on diabetes for that first chronic care management program, and you'll see why on the next slide. In the star ratings program, there are clinical measures, administrative measures, and process measures. All are focused on making sure members are receiving good quality care and that they are satisfied with the health plan and the care that they are receiving. The clinical measures that your team can help us with are focused on preventive cancer screenings and diabetes management. In a senior population or long-term care setting, these quality indicators often take a back seat as there are other complex things that members are experiencing. Members may not want to focus on cancer screenings or managing their diabetes, but it really is important. These quality indicators are based on industry standard clinical and preventive health guidelines. Members 65 and younger living in a long-term care setting obviously would benefit from breast cancer and colorectal cancer screenings. We realize that the breast cancer screening measure is one that is a little bit more challenging because that requires a mammogram that is usually off-site. Considering mobile mammography screenings that may be an option to make sure vulnerable populations can be screened with minimal disruption in routine. For colorectal cancer screening, it doesn't always mean the member has to be subject to a colonoscopy. An annual stool test can be done at bedside, and that would be sufficient if repeated every year. Educating members and their families on the importance of prevention and early detection is key. For diabetes management, particularly those members 65 and younger living in a long-term care setting, there are a few key tests that we need your help with. Tracking blood sugar or A1C results to monitor and make sure that members are under control or less than 9. We will use the last result of the year in our data analysis in order to evidence that the member's management has resulted in their diabetes being controlled. For eye exams, this is another one that can be challenging because it may require the member to go to a specialist off-site. However, we do have a handheld retinal scanner in our possession that we can send a clinician or a nurse out to do on-site screenings. You may be hearing from us to get those members screened for retinopathy. The final one here is kidney health evaluation in patients with diabetes. This one is challenging in a long-term care population because it requires a blood test and a urine test. The blood test we see happen pretty routinely in this population, but it's the urine test that's challenging, as you can imagine. We need a quantitative urine test that looks at albumin and creatinine ratios. In an outpatient setting, lab requisitions have a kidney profile option that includes the required tests. In a long-term care setting, the lab requisition does not likely have that option. Just make sure that the correct urine tests are being ordered on those patients at least once a year to identify any needs that they might have related to their kidney health. Finally, the link on this page takes you to a priority measure resource. It outlines some of the information that I've already reviewed, but it also provides some Part D or pharmacy-related quality measure information. Next up, Tarek will go into more detail about Part D topics, including the related Part D quality measures. Thanks for being our partner in quality improvement.
Hello, my name is Tarek Syed, and this is Pharmacy Services. Part of what we do here at Pharmacy Services is the oversight of the Part D Star Ratings program. Medicare uses a star rating system to measure how well a Part D plan performs. Ratings range from 1 to 5 stars, with 5 being the highest and 1 being the lowest. These measures are designed to promote prevention and treatment of chronic disease with the end goal of improving patient outcomes. The Part D star ratings are medication adherence for diabetes medications, medication adherence for hypertension, the RAS antagonist, medication adherence for cholesterol, statins, statin use in persons with diabetes, concurrent use of opioids and benzodiazepines, and polypharmacy use of multiple anticholinergic medications. CMS defines medication adherence as the percent of plan members with a prescription for a medication who filled their prescription often enough to cover 80% or more of the time they are supposed to be taking the medication. This definition applies to diabetes medications, renin-angiotensin system antagonists, and statins. The member must have at least 2 fills of the medication on different days, and the first fill of the medication must start 91 days before the end of their enrollment period. Any member who is on ESRD or hospice is automatically excluded from this measure. CMS calculates adherence using proportion of days covered, PDC, which is a fraction consisting of days in a period covered by a medication as the numerator. The denominator is total days in a period. For example, if a member has 60 days worth of medication in a 90-day period, CMS will take 60 over 90 into a percentage of 67%. That rate is under the 80% threshold, so this member will be considered non-adherent. Some definitions as they relate to pharmacy services. A formulary is a list of prescription drugs covered by a prescription drug plan. It is also called a drug list. Prior authorization is the process that the plan uses to determine if a medication is medically necessary. Therapeutic interchange is the practice of replacing, with the prescribing practitioner's approval, a prescription medication originally prescribed for a patient with a covered alternative prescription medication. And lastly, deprescribing is the process by which clinicians in a geriatric setting review medications to determine if the drug is necessary, effective, problematic, contraindicated, or causing adverse events or drug interactions. Medication Therapy Management, the MTM program, is a CMS required program. Members qualify by having at least 3 of the following conditions or diseases, such as chronic heart failure, diabetes, and hypertension, take at least 8 covered Part D medications, and are likely to have medication costs of covered Part D medications greater than $1,276 per year. Polypharmacy is especially important as it relates to deprescribing in our elderly population. Polypharmacy is simply defined as the multiple use of medications by a patient. It impacts older adults due to declining drug clearance as well as increased sensitivities to longer-acting drugs, resulting in undesirable side effects. Beginning in 2025, Medicare Part D includes 2 star ratings that relate to polypharmacy. Concurrent use of opioid and benzodiazepines, which is the overlapping use of an opioid and a benzodiazepine together, and polypharmacy for multiple anticholinergic medications, which is the concurrent use of 2 or more anticholinergic medications. Certain members will be excluded from the polypharmacy and opioid and benzodiazepine measure. Any member who is on hospice is automatically excluded from the polypharmacy for multiple anticholinergic medications. Similarly, any member who is on hospice, cancer, sickle cell, and palliative care is automatically excluded from the concurrent use of opioid and benzodiazepine measure. Deprescribing is especially important as it relates to polypharmacy in our elderly population. Deprescribing consists of guiding principles intended to help a provider curate and tailor specific intervention based on a patient's disease state. A balance is required between over and under prescribing, and oftentimes clinicians have to individualize care based on the risk and benefits to our patients. SUPD is another Part D star rating. CMS qualifies any diabetic member between the ages of 40 and 75 as a candidate to be put on a statin for prevention of atherosclerotic cardiovascular disease. Exclusions include any beneficiaries with ESRD, hospice, rhabdomyolysis, prediabetes, and PCOS. Prior authorization forms can be found on each plan's respective website by clicking on the Form Members link, then clicking Plan Documents and scrolling down to Member Policies and Form. The forms are located under Prescription Drug Determination Request. The pharmacy formulary and directory can also be found on each plan's respective website. You click on the For Members link, go to Plan Documents, and then under Prescription Drug Resources, the formulary and drug list will be available. Transition fills are especially important as we have new members enroll into our plan. As per CMS regulations, a new enrollee to the plan or a current member that has a level of care change is eligible for a transition phase. A transition phase allows coverage of non-formulary medications that they may have been receiving from a previous plan or hospital. During this phase, a member is allowed up to a 31-day supply of a non-formulary medication. When a member receives a medication during this phase, the member and provider will receive a letter informing them of the transition fill, allowing them two options. A. Switching the member to a clinically effective covered formulary alternative, or B. Submitting a coverage determination requesting Navitus to allow a non-formulary drug to be covered under our formulary. Thank you for your time. For any Part D related issues, please email us at pharmacy@curanahealth.com.